Dr. Theodore is the head of the neurosurgical spine division at Johns Hopkins, and he's co-director of the Carnegie Center for Surgical Innovation. I'm very happy about that. He's an entrepreneur and innovator in surgical robotics, and has been with us at Hopkins for close to
a little over a year.
Yeah, comes to us from the Barrow Institute, which is a world-recognized spine institute in Arizona. Thanks, Nick.
Thanks, Jeff. Well, we're gonna change tacks a little bit here, and first of all, thank you very much, Matt, and everybody for the invitation to come here today. I'm deeply honored here, and I would be remiss if I don't mention one of my favorite neurosurgeons, Lars Leksell, obviously a Swedish neurosurgeon, who's really a forefather of image-guided surgery and stereotaxis in the brain, and you know, reading his papers from 50 years ago really sets the story for where we've gone in image guidance and robotics. And I think that you know, aside from that, being, you know, deeply humbled.
Sorry, sir. I know you're the back user.
Oh, here we go. Perfect. To be presenting here, obviously, at the Nobel Forum. Matt's told me I was going to be getting the Nobel Prize, but I guess there was a shake-up somewhere along the line, maybe next year. So these are my disclosures. You know, there's a few acknowledgments here. Everything that's done, obviously, in science and medicine is a team approach, and as you can see here in the operating room, everybody with a red hat is actually an engineer. We have engineers in the operating room every day at Johns Hopkins, and welcome you to come join us when time permits. Let's go back in history for one moment. Let's go back to ancient Greece. Let's look at where this all started. This is Hephaestus. Hephaestus was the god of metalworking, and what he's doing here is actually using one of his tools to crack open Zeus's head. Zeus had a terrible headache, and he complained of this headache, and Hephaestus took one of his bronze instruments and cut into to Zeus's head to deliver his daughter Athena. It's not enough to have a teenage girl that gives you a headache. When Athena came out, the headache was relieved, and that really was the first description in antiquity of craniotomy. We know, dating back thousands of years, we've had this fascination with trephination for some reason or another to open up the skull to let the evil humors out. Unfortunately, we really didn't know what was going on the inside. That was a problem. And if you look at my forefathers in neurosurgery, Cushing and Dandy, a lot of doing what they did in brain surgery was very difficult because they didn't know what was going on the inside. We had very limited ability to know what was happening and where things were. So we were able to do things like pneumoencephalography, where they would actually inject air and to take your spinal fluid out, inject air, and then get an x-ray to see where the air was to see if we could try to find out where a tumor was in the brain. It was really not very accurate at all. We've had people looking to try to localize in the brain by putting electrodes to find out what part of the brain does what. And ultimately, it was really Victor Horsley, the British neurosurgeon, came up with the first sort of device, stereotactic device for the brain, putting this giant contraption on the head, and of course, really further refined by Lars Leksell, to be able to triangulate and in a meaningful way, get into the head in a precise fashion. But still, we didn't know what was going on the inside. So the tale from neurosurgery really weaves very closely with that of imaging, and what Jeff spoke to you about, and all the advances that we've made in imaging. If you look back to really the first Nobel Prize, Röntgen, you know, for the discovery of X-ray, Dandy did it. I told you about ventriculography. Igaz Moniz looked at the ability for us to visualize the vascular system with angiography, and then really we had this huge, you know, rapid expansion in technology, MRI, CT, and then ultimately stereotaxis. We were not able until very recently, in the past 30 years, to be able to touch a probe onto somebody's head and to see where they are on the MRI scan. That changed everything. And there really isn't any more a surgery that is done for brain surgery, probably in Sweden, and certainly not in the United States, that's not done with image guidance. Every single brain operation is co-registered to the patient. We can see exactly where we are. What does that alleviate? Well, it alleviates two things. One, it gets me to make sure I'm on the right side of the head. So Jeff talked to you about, so one of the critical errors, something that you never want ever to happen in your entire career as a neurosurgeon, is to open up somebody's head on the left side and the tumor's on the right side. Well, when you're co-registered to an MRI, the likelihood of that happening is not zero, but it's as close to zero as you can get. The second thing it does is increase our accuracy, right? In days of old, we would open up and take half of the skull off and look for the tumor. Now, I can take a device, touch the head, and be within a millimeter of where that tumor is. So we've got that. That's part of what we do now in surgery. And then comes the field of robotics. And this is just a very recent article. What jobs are robots going to take? Well, middle management, great. We'll be done with them. Salespeople, we've got already checkout cashiers in stores with robotics. Report writers and journalists, big data will be able to take all this data and collate it for us into reports. We don't need report writers, accountants and bookkeepers, and ultimately, oh God, you can't see it, but it's doctors. And if you look at the Watson project and you look at how big data is being called, in oncology, for instance, you can take 10,000 journal articles, 100,000 patient information, and you'll be able to come up with the best chemotherapy for that patient. There's no oncologist in the world that can do that. So we're going to be out of a job. We'll be out of a job in surgery as well. So we now move into this sort of realm of surgical robotics, and this has a very interesting history. So we go back into the 80s, and we have these robot that's attached to the head. So I told you we can look and we can use stereotaxis, the registration of CT MRI to the head, which is actually very well done and very easy to do because the skull is rigid and the head doesn't move, to be able to help us put electrodes in and do stereotactic surgery. This robot was from 1985. Dave Roberts from Vermont looked at and did some very beautiful work co-registering the MRI or the patient to a surgical microscope, so the robotic microscope would move to a certain location. RoboDoc was a venture from Russ Taylor, who is now at Johns Hopkins and director of robotics at Hopkins. He used a robot to help us drill the femoral shaft for a knee replacement. Neuromate, been around 1987. This FARO-arm was really the first sort of three-dimensional foray into, again, what we use now, which is frameless stereotaxy. But again, this really changed everything because this was the easiest way for us to register to the patient's head. Then we had some robots that really didn't do anything except hold devices. This is a robot, the Assited robot, which holds a surgical endoscope. And interestingly enough, that was used by one of my partners in Phoenix, Dr. Curtis Stickman, in the first usage, I think, of a robot in spine surgery. This device actually held the endoscope for him when he did surgery through the chest to operate on herniated thoracic discs. And you could, with voice control, have the robot move the endoscope for you. Very basic, but the company, Computer Motion, ultimately evolved into this company, Intuitive Surgical, which is probably the largest medical device company in the world now, which is the Da Vinci robot, which is a master-slave robot allowing surgeons to work within body cavities remotely. And this was really born out of the need and the desire really for medical and military applications, being able to do surgery from afar, having a surgeon somewhere out of theater operating on a patient who is brought into casualty after an injury. So we have the ability to do this in spine, and we have a variety of modalities we can use. As Jeff talked to you about, we've got CT, and all these things can be registered to the patient quite nicely. This is a patient from a couple of years ago who had a significant trauma, and you can see this burst vertebrae here, and down below we've got a slippage of the spine. And what we do in surgery now is we can put this image-guided tracker on. We get a three-dimensional CT scan. Here we are. The nice thing is, what don't you see in this picture? There's nobody in the room. The surgeon leaves. All the staff leave. Nobody gets radiation except the patient, which is actually a good thing for those of us who do this every day because our radiation exposure is tremendous. So that's a health concern for myself and my operative team. We register the instruments, and then I can take that instrument just like I do in the brain, and I can put in hardware very reliably. I use this on a daily basis to be able to help guide me in placing screws, especially in complicated cases. You see the fracture there, and you put the screws in. And your postoperative CT scan shows that you've done things well. So why hasn't that taken off? So in the brain, I told you we use that every single day. But in spine, we don't. And interestingly enough, up until 2016, about 13% of surgeons are using this. Why is that? Well, Jeff alluded earlier about the cell phone analogy, right? We have this cell phone that's very complicated, but it's easy to use. Image guidance isn't always easy to use. So I've got a generation of surgeons out there that are doing what they do very well, and they're not adopting new technology because it slows them down. So the question is, how do we get away from that? And ultimately, when you survey these surgeons, they said, listen, this interrupts my workflow. This is not the way that I want to be. I need to be able to do what I do. Well, I do have a whole generation of surgeons now in training who do like technology and who basically this will not impede their workflow. So why do we use image guidance? Well, this has to do with accuracy and precision. We want to be able to have high accuracy and high precision. I want to be able to reproduce that placement of those screws. The problem is, as I showed you, it's all done freehand. So we get that image guidance, and I'm watching on the computer screen, I'm watching on the screen, oh, there we go, and I'm not watching the patient. I'm watching the computer screen. I feel sort of like my 16-year-old who really doesn't play a lot of video games, but for those that do, that's really what it's akin to. And I need to be able to look at the patient and have that come back. Still, things happen, and there are complications in surgery. We looked only very recently. We started to look at how accurate we are when we put these screws into people's spines to stabilize them for scoliosis or for trauma or infection or tumors. We're good at what we do, but we're not perfect. And the reality is that the majority of times, even when we're not perfect, where there's a breach, where there's a screw that comes out here or is too lateral and doesn't go in the bone, most of the time they're not clinically significant. But the question is, can we do better? Well, there have been a lot of research done recently just looking at big series of patients. How accurate are we in what we do? And we realized that freehand, we're good probably 75, 80% of the time. We'll have perfectly placed screws. It doesn't sound very good, does it, if you're a patient? If I tell you 80% of the time I get it right, 20% things are bad. But ultimately, when you start looking at the addition of technology into the workflow of what we do, so when we start looking at this using navigation, that rate goes up into the 90 percentile range. So we have now the ability which exists. So I've got a problem here. So I've got some surgeons who think, and we all think, oh, we're better than everybody else. The reality is we're not. But when we think about this, we've got this technology which can level the playing field. So we've looked at various ways to measure accuracy, which we really can't do in surgery. And this is where the realm of robotics will really change everything, because right now, if the screw is in the trajectory as planned, I can't capture that. I don't know how accurate I am. Whereas when you're using a robot or another device and you plan a trajectory, I plan a trajectory and I put the screw in that trajectory. Now I can measure how accurate I am. Otherwise, we don't have that ability. So we've looked at this now in multiple series now, looking at thousands and thousands of screw placements. And ultimately, here's what we find. Conventional accuracy, up at the top, 69, 50% in the thoracic spine. And that's doing things the way we normally do. If we use fluoroscopic navigation, our hit rate increases. And if we use 3D navigation, which is the usage of intraoperative CT, we get really good. We get into the high 90 percentile range, which is really the numbers that we want to see. Why are we doing things? Why are we not using this technology? It's been difficult, but again, it gets back to workflow and it gets back to disruption of workflow, which is why it's important for physicians and surgeons, engineers, I should say, to work together to solve these problems. So now we get into this realm of spinal robotics. It's all over the place. What's going to happen? People are worried about losing their jobs, but ultimately, let's look at this upper left-hand corner. We're really worried about jobs, really, that humans do today, but machines will eventually do better. Certainly, putting a screw in is that job. 2004, the Israeli company Mazor came out with this sort of robotic positioning device. had to be attached to the spine, didn't use real-time image guidance. You pre-planned on the CT, and it would guide you and help you with your trajectory. And as it turned out, it actually helps. The problem, once again, was the fact that it took an excessive amount of time to mount to the patient, dial in the coordinates, and have the screws placed. But when you used it, it worked very well. And the accuracy rate went up significantly. But again, not largely adopted. And this picture is Neil Crawford. Neil Crawford was a biomedical engineer from Barrow, who was my co-founder of the robotics company. I said to him one day, I said, Neil, every day I'm looking and I'm using image guidance. Why can't I pick the trajectory on a screen and have the robot go there? I mean, how hard can that be? And he said, well, actually, it could be very hard. So we started looking at what we wanted. We wanted to be able to build something that would allow us to do things that we can't do. For instance, putting in screws in without opening the patient up, putting screws in through the skin with sub-millimeter accuracy, reducing radiation exposure, because again, most of the time when we put screws in people, using X-ray or image guidance, but we're shooting multiple X-rays, and I'm standing there shooting those X-rays. So we'd like to reduce that. We'd like to be able to increase our consistency, and I want to be able to plan. I want to be able to look at the CT scan and draw it with my finger or map out where I want the screws to go, push a button, and then have that robot take us through that workflow. I want to see in real time where we are, and I want active feedback. I want to know when we're deep whether or not that robot's being deflected. So these are all important things. So again, this is a collaboration between engineers and surgeons. I come up with my wish list. You all and those in the scientific community and my engineering colleagues, okay, we can do this, we can't do this, what's more important? And it becomes a give and take as you work through this process. I wanted automatic registration. Jeff's talked about that. That we have, not difficult. I want to be able to correct for motion. What if the anesthesiologist moves the bed, the table goes up and down, the patient coughs? I don't want the robot to be able to put the screw into the wrong place. I want it to be efficient in the workflow. As I told you before, all this technology is going to fail and never be, seen outside of a laboratory if it doesn't integrate into workflow. So really the mantra has to be is integration and taking that clinical idea to the lab and then back into the operating room once it's refined. And it can't be disruptive to our workflow. The arm needs to be rigid so we can drill through it. We want to be able to collapse the time of our procedure. We want some sort of force feedback control. And then there are those constraints which are characteristic to robotics in general. So this is my first foray. You look at the date down here, 2002, I thought, well, this would be great. I will sit here at home with my cappuccino, and I will plan out my surgery, and the robot will come in and do something like this. This was my first sort of conception of this. And Neil looked at me and said, that's not going to happen. I said, why not? He said, I have 3 letters for you, FDA. So the Food and Drug Administration is never going to go for this. It's a completely autonomous robot that does this. So I said, okay, well, let's start here. So we started in the lab, and we started being able to draw out the algorithm and the computer programming, which is an enormous part of this project, to be able to get the medical image registered and then have that arm move to that location precisely, time and time again. Look at this equipment. This is, again, over 10 years ago. We were able to do that. We then start talking to mechanical engineers, electrical engineers. What does it look like? How many degrees of freedom do we want? How do we build this so that it's unobtrusive? We can't have this enormous thing over the patient. It's got to be streamlined. It's got to be rigid. It's got to be accurate. There has to be force feedback. These become significant engineering problems. This was their first foray. This is we called Old Blue. And Excelsius is the name of the project, 6 axes of freedom, basically fully integrated to 3D imaging. This is just going to quickly show you the very basic at the beginning, being able to, once again, plan where I wanted things to go. This is on a reference frame. I said, okay, I want a screw to go down this trajectory. Again, very basic. Planning your screw trajectory, and then ultimately having the robot take you to that trajectory so that you can do something very simple as putting a screw in. We were very excited when we did this. Then we said, okay, well, what is it really going to look like? And this is sort of our rendition of what we thought it was going to look like. And then when you start realizing that this can be done, where you can automate that accuracy and positioning, you realize then there are a whole world of possibilities. That whole world of possibilities includes using any type of imaging to integrate with robotics. And then not settling just for putting a screw in. That was the first iteration here. But why not do something like a biopsy? And if you've ever seen somebody have a CT-guided biopsy, even to this day, it's an awful experience. The radiologist takes a needle, sticks it in the patient, puts him in the CAT scanner, sees where the needle is, they come out, he puts it in further. And you go back in the CAT scanner 3 and 4 times as he tries manually to pierce the tumor with the needle so that he can do a biopsy. Why in 2017 are we doing that to patients? Can we not automate that? And the answer is, of course we can. And ultimately, that is going to be coming very soon. This is the robot as it stands now. And ultimately, again, as you see it here, the design features are such that it is on wheels. It's fully mobile, comes into the operating room. It is married to, it has its own built-in image-guided system. And what we do now is basically we get our intraoperative CT scan, we wheel the robot in, we're able to place hardware in 5 and 10 minutes, which sometimes would take an hour previously. Robot can wheel out, go next door where somebody else can use it. So again, not disruptive to workflow. And this is just showing you the technology. So you've got basically everything has to be controlled. It has to be a separate feedback control. But once that trajectory you've locked on, again, we're doing this procedure percutaneously, so the skin's closed, but you can see the diagram of what's going on underneath. And interestingly, what we've got is that ability to watch in real time the screw head, and it's a beautiful thing to watch the screw pierce the skin percutaneously, hit the bone, and as you're hitting the bone, you're watching it on the screen hit the bone, and that representation as the screw goes in. Really is going to change what we do. So this is the pre-planning phase. On the left, we're picking what we do. On the right, it looks like there are too many people in the operating room, and there are. This is our first case that was done on October 4th. And again, these collaborations, really are in a small way like any scientific endeavor. And ultimately, when we've got the engineers in, seeing the work, their hard work, and everything that everybody has put into the project come together, it's a great feeling. I said to myself, if it didn't work that day, I probably would have to move to Sweden. And this is the arm here. This is actually the first screw going in, drilling. And that arm can withstand about 180 pounds of force. So literally, most people, not me, can stand on that arm and it doesn't move. Again, you don't want anything to be bumped or moved when you're instrumenting the spine. And this now is the screw going in. Again, you see the fiducials on the screwdriver. That you've got, where the patient is, where the screwdriver is, and everything comes together. And literally, we're watching on the screen as that screw goes in. So as I said before, this opens up a tremendous possibilities with all of medicine, biopsy, focal therapies, and I believe that the future is very bright for the whole field of image-guided surgery now, because we've sort of, once we get through the workflow, we realize if we can stereotactically target something, not just radiation, but other focal therapy, chemotherapy, biopsies and things like this, it's going to change the way we practice medicine. So remembering that the future is now, ultimately, that the robotics are here. I don't think anybody in this room is going to lose a job, hopefully, over this, but we can continue to get better at everything we do. With that, I'd like to thank you very much for your time and attention.